Perfect, thank you. That's good. Okay, it's 1 o'clock. So, hello everyone, and welcome to week 2 of the Pandemic, Science and Society. It's week 2 of this class, but I don't know, week 5 million or something of the actual pandemic. Our first guest today is Dr. Rachel Penczykowski, who is a professor in the Department of Biology at Washington University in St. Louis. She is going to be talking to us about understanding the numbers of COVID-19. Welcome, Dr. Penczykowski.
Great, thanks, and thanks for inviting me to participate in this really fantastic course. I've enjoyed watching some of the earlier lectures. So I will share my screen. All right, can everyone see the obligatory phrase of 2020? Great, so the goal for me today is to give you the tools to really understand some of the numbers that you've been hearing about in the news, so that you can then share what you've learned and help other people understand what these numbers mean. So we have a lot to go through, but I'm going to try to cover it at the most basic level to really set up a framework for understanding what all these different types of numbers and ratios and graphs mean. I want to start by acknowledging the many people who helped me prepare to give a lecture like this, including students in the disease ecology class that I teach here at WashU. We did have a disease ecology semester in the midst of an unfolding pandemic. And it really was a way for us to learn all of the concepts of the syllabus in real time, which was, of course, traumatic in its own way, but was also a chance for us to kind of have some community together in that class experience. And we did a lot of discussion of all of these unfolding questions as they were arising. So I want to give a little shout out to the students who were there with me working through a lot of these conversations. And then more recently, I've had many really helpful conversations with a bunch of folks who are disease ecologists, epidemiologists. These were, of course, all virtual conversations, but very stimulating. There's a lot of really valid, interesting scientific discussion that happens on Twitter, and that is, in fact, where a lot of this discourse has occurred. So all of these folks you could look up on Twitter if you were so inclined. And I want to start by giving you just a little bit about the perspective that I bring to this topic. So in my own research, I study the ecology and evolution of infectious diseases in non-human hosts. And two of the systems that I've worked in the most are Daphnia, so small aquatic zooplankton, aquatic crustaceans, and they're fungal parasites. So you can see in this picture, the Daphnia on the left, she's full of a fungus that's just growing throughout her entire body cavity, and it will kill her. The one on the right is uninfected, and they're transparent. They're abundant in nature. You can manipulate them quite easily in the lab, so they're really great model organisms, but also ecologically relevant ones. And my lab here at WashU primarily focuses on interactions between plants, specifically Plantago species, and their powdery mildew pathogens. So this is another fungus. It's also really easy to see, which I appreciate. And so in these study systems, we can ask many of the same questions that epidemiologists who study human diseases ask. However, we have a lot more control over our study subjects, which I think, as you'll see in the slides throughout this lecture, is really a beautiful thing, and one that we're not so lucky to have when it comes to understanding diseases of humans. There's just a lot that we can't know for a variety of reasons. And so I, in my own research, like to study these very tractable systems, but also the reasons why those systems matter to the broader ecosystems in which they occur. So they're models, but they're also, I think, ecologically and evolutionarily really interesting in their own right. But those of us who study animal and plant diseases, we really learn a lot by talking and collaborating with folks who study human diseases and in the other way as well. So we can use mathematical models as a common currency for discussion, as well as reading each other's papers, going to interdisciplinary conferences, and joining societies of people who study diseases in lots of different types of hosts. And in fact, this crossing the host taxonomic divide, as it's sometimes called, can lead to some really novel insights and innovations, and keep people in a certain field from reinventing the wheel every time a new disease pops up in their type of study organism. There's a paper I really like that was published just about a decade ago by Elizabeth Borer and colleagues in the journal EcoHealth that we discuss early in the semester in my disease ecology course. And it's always a very, I think, stimulating conversation about what we can learn from thinking outside of our own little tunnel visioned subdiscipline in biology. So I'm going to tell you about the numbers of COVID-19 in 3 parts. Part 1 focuses on how many people have been infected, how many have died. So how do you estimate past and current numbers of infections and deaths? And also, what can we learn from the demographic information about who has been infected and who has died? In the second part, we'll talk about understanding your own risk of infection and how that varies with space, time, and the circumstance in which you find yourself, or which you are thinking about finding yourself. And we'll briefly discuss, that life and death are, of course, the stark outcomes of contracting COVID-19, but there's a range of other possibilities, and a lot of that we don't know about in terms of the long-term health impacts of being infected. In part 3, we'll talk about how you can model how bad a pandemic might get and what types of strategies might stop it from getting that bad. So we'll talk just a little bit about the framework that epidemiologists use to model infectious diseases and to evaluate control scenarios. So these are the big topics. Of course, we don't have time to go too far in depth into any one of these, but these are the main themes that I want us to touch on today. So let's start with part 1. How many people have been infected? How many have died? So back in January, towards the end of January, I saw a post on Twitter to a blog post by a scientist named Rich Lenski. He's a microbiologist, very famous for his microbial evolutionary studies. And as this new novel coronavirus was unfolding in Wuhan, in China, he started to think about how one might just start to estimate kind of a back of the envelope calculation of the total number of infections that were in Wuhan at the time, based on the information that we had. And so we did this little exercise on the real chalkboard in our disease ecology class. And so I thought I would just, to kind of start the most entry-level math. I know it's the beginning of the school year. We all might be a bit rusty. Trust me, this is just arithmetic, so you're going to be fine. So what did we know at the end of January? Well, there are about 1.4 billion people in China. And in Wuhan, there are about 11 million. So, thinking about rates at a national level, we might want to calculate as a starting point what fraction of China lives in Wuhan. And the answer is about 0.8% of the Chinese population. We also know from a variety of sources that something on the order of 3 million Chinese travelers come to the US per year in an average year. And so if we wanted to just very naively estimate the fraction of, the number of travelers coming from Wuhan, China to the US per year, we would just do this simple multiplication, 3 million times that 0.8%, and we get something like 24,000 travelers from Wuhan, China to the US per year. If you convert that to weeks, again, this is just arithmetic, that's about 500 travelers a week. And so what we knew at the time, at the end of January, is that there had recently been 5 travelers from Wuhan to the US that were found to be infected with this new coronavirus, which at the time was called nCoV 2019. And so we could say that there's an infection rate of 5 out of the roughly 500 people who were entering the US. That's about 1% of the Wuhan population. And so again, just a really rough estimate, something like 110,000 infected people might be in Wuhan at the time. So that, as the title of the blog post suggests, is a very quick and dirty way to go about this type of estimate. But it turns out that that estimate fell very squarely within some of the estimates that folks were making based on a lot more information and a lot more sophisticated models. And so, as you're thinking about how epidemiologists figure out some of these numbers, you can start to think about the very basics, like what information do we have and what is sort of the coarsest level ballpark estimation that we can do. So more recently, there was a paper published in the journal Proceedings of the National Academy of Sciences by Alex Perkins and colleagues, where they actually, in a much more sophisticated way, attempted to estimate those unobserved SARS-CoV-2 infections in the United States early in spring, before testing capacity had really ramped up. And what they found through some modeling efforts, which they calibrated against the actual data at the time, they estimate that thousands of infections went undetected and unreported in the first few months of 2020. And that, in fact, less than 10% of all of the locally acquired in the United States symptomatic infections might have been detected during the month prior to the 12th of March. And so that's really critical because that was our chance. That was our chance to really stop this pandemic from becoming as bad as it became and as still is. And so that would have been the critical window to really test a lot of people and figure out how to isolate folks and keep things from spreading, but that did not happen. And so there was a huge number of infection events that happened and went undetected and then spread all through the United States just around the time that schools like WashU, well, schools everywhere, realized that they could not continue an in-person semester in the spring. So the 12th of March was in the middle of our spring break period, as I recall. And that was when collectively across the world, people realized we have a massive, massive problem. And we are only now, months later, able to look back at the data and the data we've collected since then and try to quantify just what happened in that time period. So far I've just been reporting things in terms of numbers of cases, right? But there's a lot of different metrics, different indices to quantify how much disease is in a population. And these include words like positivity, prevalence, and incidence. And so before we go any further, we need to clarify what these things mean. So you may have heard about test positivity rates. So this is the fraction of the positive tests out of the total tests performed. Now, this might be, you might think of this as really reflecting the total fraction of people who are infected in the population. But as we know, not everyone gets tested at a given place in a given time. So we really need to remind ourselves what this rate is comprised of, what's in the numerator, what's in the denominator, and how variation in, for example, the denominator, the number of tests performed, whether repeat tests on the same person are included or whether these are unique individuals tested, what time period this number of positive tests, the number of tests performed is averaged over, for example, because we don't want to confuse it. I'll go back to that pop-up window in a second. We don't want to confuse it with another estimate of, for example, prevalence. So here, for example, point prevalence would be the current cases at a point in time out of the total population at that same point in time, right? So for this metric, the denominator is the total population size, which typically includes a lot of people who haven't been tested for a given infection. And if we look at the current testing data in the US as of this morning, when I screenshotted this bit of the CDC's dashboard on testing, we see that there have been in the US more than 74 million tests reported, more than 6 million of those have been positive, so about 9% positive tests. But that is not the same as saying that 9% of the US population has been infected, because a lot of us have not been tested. Another index that you may have heard about at some point is incidence. And incidence is the number of new cases in a time interval out of the average population during that time interval. And so it's different from prevalence, because prevalence might include both current and past cases. It's not, we don't know from a prevalence estimate just when exactly those cases were acquired. Okay, so these are three really critical definitions. But the bottom line is, to get a good idea of infection levels in a population, we really need to know a lot about those denominators and those numerators. And so we need to get a lot of tests done on a lot of people. We need to test people frequently, and we need to test people quickly, because if there's very long lags between when a test is administered and when we have the results, it really messes up our ability to estimate any of these indices. And we all know that these are the types of numbers that we hear in news reports, and they really inform our actions. They inform how we respond to this unfolding pandemic. And so, because these different types of ratios, these different estimates are really, really different, we need to be super crystal clear on how they're measured, how the data are collected, and how they're being reported, so that people are not being misled and making policy decisions based on not the information that they thought they were interpreting. Another type of definition to clear up has to do with how deadly a disease is. And so here we're talking about IFR and CFR, where IFR is the infection fatality ratio, which estimates the proportion of deaths among all infected individuals. And the case fatality ratio estimates this proportion of deaths among identified confirmed cases. And so, just reading these quickly, these sound really, really similar, right? Like, okay, so it's the proportion of deaths. But the critical part is that denominator, right? So the infection fatality ratio is across all infected individuals, whether those infections were tested and confirmed or not. Whereas the case fatality ratio is just out of those that we know were confirmed to be infected with COVID-19 through whatever type of diagnostic testing. So this is a really important distinction. And the dynamics of these, and especially of that infection fatality ratio, can really change over time due to lags in testing, lags in processing samples, lags in reporting samples, underreporting of fatalities, but also due to improvements in the standard of care, right? So one reason why the either the infection fatality ratio or the case fatality ratio might improve through time is if we are getting a better handle on how to treat patients and how to recognize symptoms and keep people alive. Of course, just looking at these snapshots of national level data really doesn't tell us about who's getting infected. And so collecting demographic information is really, really important for seeing which communities are being impacted the most and what's driving that differential impact. And so probably unsurprisingly to everyone here, Black folks in the US, Indigenous folks in the US, and Latinx folks are being disproportionately impacted and dying at higher rates than white folks in the US from COVID-19. And so there are now a few different really nice dashboards and tools for exploring these data, which I've linked to here. And this graph that I've shown you here is from the covidtracking.com webpage, where they report that Black people are dying at almost 2.5 times the rate of white people from COVID-19 in the US. And the numbers here are just truly astonishing. And again, bear in mind that this is just looking at mortality, right? So this is not taking into account other long-term health consequences, economic impact, other types of impact. This is just deaths per 100,000 people by race or ethnicity. So these are truly horrifying trends here in our nation. And I want to be perfectly clear that this is explained by systemic racism. This is not explained by the virus, preferring one group of people over another, or biologically succeeding in replicating in one race over another. This has to do with all of the ways that racism affects factors in a person's life, including their risk of exposure to the virus in the place where they work, in the place where they live, probability of other underlying health conditions that impact their prognosis, access to medical care, and also how people are listened to and treated by medical providers. So these are the things that drive these disparities in the impact of COVID-19 here in the US. So again, that's kind of still thinking at these big aggregate levels, the levels of populations or demographic groups. But it's really important for each of us to be able to conceptualize our own risk of infection, because that, of course, is something we all want to know, but it also helps us better protect other people in our lives and in our communities. So we need to keep ourselves safe for the sake of keeping ourselves safe, but also keep ourselves safe so that we can protect others. So we need to understand our risk of infection and how that varies. And so one tool that has been developed for trying to help humans understand our risk are these types of color-coded warning levels, which are all fairly intuitive from other cultural references, traffic lights in particular. And so this is the color scheme from the Harvard Global Health Institute, the globalepidemics.org webpage, where they have these risk levels ranging from green to red, where green is really great, you're on track for containing this disease. Yellow suggests community spread, so you ought to really rigorously test people and trace their contacts. Orange means accelerated spread, so people should be staying at home and really avoiding interacting physically with other people, and you really need rigorous test and trace programs. And then red is very bad. This is the tipping point where stay-at-home orders are necessary, and we really worry about things like hospital capacity. And so this globalepidemics.org webpage dashboard has these really nice maps that are color-coded. This is the US map, but you can also look at the worldwide map, and you can look at the county level at what your risk is. And so as of last night, when I took this screenshot, St. Louis County, Missouri, we're at a level orange. So again, to remind you what that means, this is accelerated spread, where folks should be staying at home or there should be very rigorous test and trace programs in place. And this dashboard also reports, in addition to the color level, what that daily new cases per 100,000 people is at this time, and it's about 18 right now, which means daily new cases, 7-day moving average, about 182, and also in the county in total, there have been almost 17,000 cases and over 700 deaths. Okay, so these are some specific numbers for our region. But I don't know about you, these numbers really still don't hit home to me. Like, I mean, I get it, that's bad, and orange is kind of a scary color in this color scheme, but it's hard for humans to think on the order of like number of cases per 100,000 people, 7-day moving averages. Even if you work with numbers or even epidemiological numbers for your job or your research, like this is really hard to conceptualize and also very hard to communicate other than saying, you know, hey, it's an orange level, stay home. So I really like this other tool that was developed by researchers at Georgia Tech, along with folks in the Applied Bioinformatics Laboratory and at Stanford. And this frames the same type of risk level, but in terms of a metric that's a bit easier to conceptualize, and that is the estimated chance that at least one COVID-19 positive person will be present at an event of a given size in each county. And so this is another free online interactive web tool. I think if you went back and forth between the two maps, you would see correlation in the red areas should be similarly red in those same geographic regions. But what we can do with this tool is we can toggle the event size. So either the size of an event that you would like to plan, or the size of an event that you are considering attending or worrying about someone you love attending. And you can also toggle the ascertainment bias. So that's telling us how underreported are the total number of cases in this area. So a 10-to-1 ascertainment bias would say, based on zero prevalence data, we assume that there are 10 times more cases than are being reported. So in places that are testing a lot more and a lot more frequently, that might be lower. It might be closer to 1, where the actual numbers reported reflect the reality of the numbers of infected in that place. And so what we can do here is, again, zoom into St. Louis County. And so we see that for an event size of 100 people, with the assumption of a 10-to-1 ascertainment bias, the current risk that at least one person is COVID-19 positive in that group of 100 people is 96%. And in fact, much of the US is currently at that more than 90% level of risk for gatherings of 100 people, especially in the Southeast, but increasingly elsewhere. So that kind of hits you in a different way when you think about it like that. You can toggle the event size all the way down to 10, make yourself feel a little bit better maybe. That I think that if you toggle it to 10, an event of 10 in St. Louis today, the risk is only about, between 15 and 20%. That's still pretty high. That's a high risk in a group of 10 people that one of them is going to be infected. So I encourage you to look at this tool, play around with it, check out your hometowns, places where family and friends live, and really try to get a grasp of what these risk levels look like. You can also, with this tool, take a look kind of more in depth at how some of these other parameters affect your risk levels using this real-time US and state level estimates tab. So you can produce plots through this tool, where here on the x-axis is the number of people at an event on a log scale. So going from a small dinner party to an NFL game. And the y-axis is the current number of circulating cases in that place. So I selected Missouri for this plot, and then the plot is automatically produced, and it shows you based on the current reported incidence, and then the ascertainment bias of 5 times or 10 times that, what is the current risk that there's at least one infected person in that group. So again, if we look at an event of 100 people, this vertical dotted line at the x-axis of 100, or a wedding reception, which hopefully none of you are going to anytime soon, we would see that based on the current reported incidence, there's more than a 14% chance that at least one person is infected, assuming that the reported incidence matches reality. if we assume a 5 times ascertainment bias, there's more than a 50% chance that at least one person's infected, and then 10 times the risk goes up. So this is another way to visualize how the level of infection in the region and the size of an event, and what you know about the testing levels, how that shapes your actual risk at the county level. And I really also like this explanation that's given in this COVID-19 risk calculation webpage, because it walks you through how that's calculated. And so rather than calculating, rather than estimating the chance that one person at the event is already infected, what you're actually doing is thinking about the chance that none of the people at the event are infected, and then ultimately subtracting that from 1. And so in this example of a huge event, an NFL game, if you think about current levels of infection in the US being something like 20,000 out of 330 million people, that means each person themselves only has, a 99.994% chance of being, each person does have almost a 1 chance of 90, let me start again. Each person has a 99.994% chance of being disease-free. That's good, right? That's great. We're doing awesome. So in terms of the odds there, like, excellent. But the collective risk gets very different very quickly. So if you use those same odds for all 75,000 people at a big event, what you have to do is multiply the probability of not being infected by itself 75,000 times. And then the chances that all of those people are uninfected becomes very slim. And so you can read through this word problem yourself, because it might take a little bit to wrap your head around, but it does work out that the chance that 1 or more attendees would have arrived infected with SARS-CoV-2 is 99%. So I think that's another great way to conceptualize how this works and also how this can be calculated. Of course, the risk of infection is not evenly distributed, even at the relatively fine scale of the county. There's a really nice article in the New York Times published back in June about the heterogeneity, the variation in which cases actually cause additional new cases in the population. And a number of recent papers, both those that are still in the preprint, yet to be peer-reviewed stage, and increasingly those that are now coming out, being published in journals. And there have been, as you have probably heard by now, a lot of clusters of cases linked to environments like prisons, like meat processing plants, like healthcare facilities, nursing homes, daycare centers, restaurants, bars, and social gatherings. And so it's really the circumstances of being together with other people, especially in an indoor environment, especially with poor ventilation, and especially for a prolonged period of time, that dramatically increases the risk of being infected. And then there are additional activities in any of those scenarios that can further amplify the risk, like talking a lot, singing, things like this. So one way to visualize what that heterogeneity in transmission looks like is to think about the super spreading events, the probability of them. And so if you take a look at the top row of figures in this figure, the y-axis in these are the dispersion parameter K. So this is telling you something about the distribution of transmission events, and whether they are, whether typically people are infecting very few people, and So whether the average person infects very few people and there's very little variation around that, or whether the average person infects very few people, but then there's a very long tail to the distribution where there's a very wide dispersion. And so here, the key metric is this value K, and a K of less than 1 indicates that there's a lot of heterogeneity and that there's a lot of super spreading. So there's a small number of transmission events that result in a lot of new infections. And so each of these panels in the top row and the bottom row, but each of these separate panels as you march along is a different county in the state of Georgia. And you can see that those plotted points are all below this threshold value of 1. So there's really significant super spreading. These 1, 2, and 3 are different time periods in the epidemic. And then another way to think about what super spreading actually is to look at the mean number of new cases produced by an original case. So the mean number of offspring cases generated by cases. And in this study, the authors broke that into different age groups of the originally infected person. So whether the transmitter of disease was less than 60 years old or greater than or equal to 60 years old. And what you can see is that there were a lot of these red dots where there's a really high number of mean offspring, especially for folks in the younger age bracket. So about 2% of cases were directly responsible for 20% of all new infections. So super spreading is more the rule than the exception in terms of what's driving community transmission here. And so one way to try to figure out how these super spreading events happen is to do contact tracing. And so I want to just briefly walk you through what that is. So the key step for this test, trace, and isolate strategy, and you really need all 3 combined to be an effective tool for mitigating disease. So isolation is when you separate someone who is infected, whether they're symptomatic or not. Quarantine is where you separate someone who might have been exposed. And that's a really important distinction in terms of what the role is, but in practice, it's kind of the same. You stay by yourself. So people need to quarantine if they've been in close contact with somebody who has COVID-19. And what counts as close contact is defined here by the CDC. I'll let you read these guidelines yourself. And there's been a lot of buzz about, contact tracing with phone apps to complement manual efforts at tracking people down. So in this example, person A is asymptomatic, but they are sick with COVID-19, or they're infected with COVID-19, and they have a hypothetical app on their phone that pings other people's phones nearby. And so after they've gone about their day on the train, at work, back home, and realize then that they're waking up with symptoms and they get tested, then this app would alert each of the people that had been nearby them during the day, but only recommend quarantine for those that were the closest to them during the day. So this lucky person H and I, who work with this patient A, they were nearby but not super close, so they're advised to socially distance but maybe not quarantine. However, manual contact tracing is still really the key thing that's happening. There's a lot of barriers to rolling out a successful app for contact tracing. There's issues of privacy, equity, of technological interfacing between different types of phones. And there's been very little actual research comparing the efficacy of apps versus manual contact tracing. So a recent review that came out that I've linked to here really highlights that we're not ready yet still, at least in the US, for totally app-based contact tracing. We still need that manual component. We'll see how that changes in the coming months. So to kind of summarize this part of the talk, to reduce your risk of infection, you really got to follow these 3 C's, right? So avoid these 3 C's. Avoid crowded places, avoid close contact settings, and avoid confined and enclosed spaces. And also recall the other really great practical advice that, for example, Jose Jimenez gave in his recent lecture. Even though surface-based transmission seems to be playing a relatively minor role in community spread in this pandemic, do continue to wash your hands frequently, because it's not a zero probability of spread. Do wear a mask that fits properly. Keep it on while you're talking. And I really like the advice that Jose Jimenez gave, that if you see somebody with a loose mask on, don't stand behind them. If anything, stand in front of them. So really, think like the virus. And also, I think didn't have time to actually include a slide on this, but keep in mind that when you're framing your own risk of infection, it's not just about life or death. There are so many unknowns about the long-term consequences. So you really need to weigh this risk very seriously, even if you think that you are otherwise in a low-risk demographic based on your age or underlying health, etc. So please do take this very seriously. So for thinking about how bad a pandemic will get and how we can stop it, models are really key here, because they can allow us to do experiments on a computer without having to let such experiments play out with devastating consequences in real life with real lives. And so, there's different types of models of infectious disease for different purposes. Some are useful, some are intended for just helping us better understand mechanisms, and others are intended for prediction, for figuring out what's going to actually happen next. Keep in mind that models are really only as good as the assumptions that go into them. So this phrase garbage in, garbage out. And also all models are only an approximation for reality, but sometimes that approximation is really useful. So all models are wrong, but some are useful, saying that folks like to quote in talks. So of course, I'm obligated to here. But I think that I want to stress that models are really useful for evaluating how different disease control scenarios may play out. And so what makes a good mathematical model really depends on the purpose of the model and what information you have available. There can be trade-offs among accuracy, so how accurately you can reproduce observed data and reliably predict the future. Trade-offs between that and transparency, like how easy is it to understand how these different components come together mathematically. And flexibility, how readily can a given model be applied to a different situation? Is it so tailored to a given setting that it can't be generalized? That would be a trade-off. And just to really briefly give an overview of some of the core components of models, there's this talk of parameters and variables. Maybe you remember this from previous courses. Maybe you need a little refresher. So just very briefly, parameters are used to connect variables in an equation, and they're typically a fixed value within a given equation, whereas variables are the things that vary. So they're changing with respect to another thing in a system, and they're typically the input or output of a model, such as number of infected individuals changing through time, where a parameter might be something like transmission rate. As the simplest example, let's look at the equation for a line. Y and X, those are the variables, and then the slope and intercept, those are the parameters. In epidemiology, one of the most basic types of models is this type of SIR compartment model, where S stands for susceptibles, I stands for infected, R stands for removed, which might either be recovered or immune or dead. And so the most straightforward way to think about this is boxes. So you have a box of susceptible people, a box of infected people, a box of recovered people, and you draw arrows to connect the boxes, and then you put parameters and the relevant variables over the arrows to denote how individuals move between these compartments. So susceptible people can get infected, infected people can recover in this most simple model, where beta is transmission rate and gamma is recovery rate. So this is what this model looks like in a series of differential equations. You're looking at the rate of change in susceptibles, infecteds, and recovered through time. Susceptibles only decrease through time because the only place they have to go is into the infected class. Infecteds increase susceptibles decrease through time, infecteds increase through time by getting infected, but then also they decrease as they recover, and the number of recoveries increases through time. It looks like this if you plot it through time. So the blue curve of susceptibles decreases. There's a little epidemic here where the number of infecteds increases and then decreases, and then the number of recoveries increases through time. So this is a model assuming no births, deaths, immigration, emigration, things like that. This is a way to look at the transmission processes themselves, transmission and recovery processes. And just wrapping up here in the last few minutes, one of the key numbers that you may have heard people talking about has to do with under what conditions disease will spread. Well, disease will spread if the rate of change in the number of infecteds through time is more than 0, right? So if the number of infecteds is increasing through time, that means disease is spreading. And so if you just do a little bit of rearranging of these equations, you can look at what combination of parameters and variables result in di over dt being greater than 0, simplifies to this beta si being greater than gamma I, and this term beta s over gamma being greater than 1. And we call this R naught, where R naught is the basic reproduction number or the basic reproductive ratio of the disease. So it can be interpreted as the mean number of new infections caused by a single infective individual. So in that graph I showed you a few slides back, it's that average number of new offspring cases from an initial case. And the number of infected hosts in the population will increase if R naught is greater than 1. So that's what it is. It's not as complicated as maybe, if I told you we're going to do some calculus today, on the first day on a Monday, before the semester has started, you might not have believed me that it was this easy. And so you can then use different formulations of your model to test out how different disease control strategies affect, for example, that R naught basic reproductive number. So depending on the type of disease, you might be evaluating different vaccination regimes, different culling protocols of hopefully not human hosts, quarantine measures, efficacy of different medications, behaviors that reduce transmission, vector control for diseases like malaria. And importantly, more sophisticated models need to account for the interplay of human behavior and information and learning about how these different strategies work, right? Humans are really complicated host organisms. This is why I work with plants, because our perceptions of how these different control strategies works impacts their efficacy because it impacts who uses them and who doesn't. And so just to wrap up, I've put a bunch of links to interactive modules at the end of my slides that don't require any coding on your part. They don't require you to do any calculus. You can just toggle and slide different parameters and settings to find out what some of these different possibilities for infection control look like when modeled. So to summarize, I think that epidemiological literacy for the general public, as well as for people making decisions at all levels, is really critically important at this time. Data inform action, and that determines the course of this pandemic. So we need lots of data. We need to know what those data are, how are they collected, how are they reported, and we need to know how to interpret them so that we can make informed decisions for ourselves and for people who we make decisions for, whether they're people in our families, people in our classes, people in our workplaces, etc. We need to understand not only the risk in a given country, state, county, but different situations, and think about a scenario that you might find yourself in your day-to-day, and how safe is that scenario, and what can you do to make it safer, or should you not do that? We really need to understand the disparities of this pandemic, especially racial disparities, so that we know where to focus efforts in helping break chains of transmission and make sure that people have access to safe and effective treatments. And so I want to leave you with the encouragement to dive into some of the very many really nice handy tools that people have published on the web so that anyone, whether a college student or not, an epidemiologist or in any other field, can take a stab at looking at how our actions and our control possibilities might just be able to turn things around sooner than later. Okay, so there's some references, dashboards of different statistics, and then some links to playing around with epidemiological models. And if we have time, we'll take a few questions.
Thank you, that was great. So I think you've given a lot of information that I think the students will need some time to digest, but they have some questions to help them do that. So these questions range a lot of different areas, from kind of clarifying some of the information that you talked about to asking your opinion of some more broader theoretical issues. So let me start with some of the clarifying ones. Students were wondering if you could explain again the IFR and CFR and how that works specifically for COVID. Like, if we don't know who all is infected, or we have this asymptomatic spread, how does that get worked into these calculations? And if you could just kind of go back over those concepts.
Yeah, great question. So that's where seroprevalence data really comes into play. So we want to know what's the total number of people that were ever infected in this population, who has already been infected and recovered, and who was infected and died. And so looking at your immunological evidence of prior infection is what's critical there, because we'll have, if you've already recovered, we've missed the opportunity to test you, with a swab-based test.
Yeah, that makes sense.
Yeah.
And
so the short answer is we really don't have good estimates yet for that total IFR.
That is exactly what I was going to ask. Yeah. Okay, great. And then similarly, the ascertainment bias. Can you talk a little bit more about that? Explain it, as well as how do you know what number to use for that? Like, is it 1.5? Is it 10?
Yeah. So I think that, again, the seroprevalence data can help kind of calibrate between reported cases based on PCR-based testing from a swab versus the number of people that actually were infected and it just was never detected. And so I think even in that risk assessment tool, when you kind of dig through some of the tabs and they explain the methods, I think that their estimates of up to 10% ascertainment bias came from comparing seroprevalence data to the other diagnostic, like PCR-based tests of current COVID infections. But hopefully in places where folks are returning to in-person interactions, where there are plans to massively test huge numbers of people quickly and frequently, for example, in university environments, there the ascertainment bias should be pretty low. I don't have an estimate for you on what that would be, how close to 1 it is, but that's the idea, is that if we test enough, we can actually get a good handle on the total actual number of infections, not just those that had symptoms and went and got tested, or had an exposure and went and got tested. So that's the whole reason for that's the reason why places like universities are rolling out huge testing programs to do in-house testing, frequently and broadly.
Yeah, and so some of the students wanted to know more about that. Like, what, in your opinion, what does a good testing strategy look like? How often would they need to be getting tested?
Ooh, that's a good question. I know there has been some good discussion on Twitter surrounding UIUC, so University of Illinois Urbana-Champaign, and their testing protocol, which my understanding is one of the more rigorous ones. But I think the jury is still out there, right? So universities in the US are, at most 1 or 2 weeks into their semesters and just starting to see how each of their strategies plays out. So I think it remains to be seen. I don't have, I can't tell you, test everybody Tuesdays and Thursdays. I don't know at that level, But I just know as much as possible and as frequently as possible, but I know there are lots of people working very, very hard on trying to figure out the logistics of that so that, you are getting data in a quick, with quick turnaround time and able to process the data in order to react.
Yep, that's great. Yeah, so related to that, a lot of students put in the question box that as they were looking at the maps and the other warnings related to St. Louis in particular, it was making them feel kind of nervous or intimidated about returning to campus. So what can you say about that in terms of seeing those numbers and then knowing that we have this plan to return to campus probably in a few weeks?
Yeah, to be quite honest, I think it is very scary. I think you're right to be alarmed and to be taking this very seriously. This is in my own family, we've had, discussions about how we're going to keep ourselves safe this semester. So I think you're right to be concerned. The orange and red colors are there for a reason to look like scary and intimidating, because things are quite, what's the word I'm looking for? Serious. Things are serious here locally. And so, I think we'll see what the plan is for frequency of testing, but certainly I think there's a lot of, assuming that everyone, does in fact come to campus, not everyone, but many people come to campus physically, that's a lot of individual responsibility to not go to big group gatherings, even if, all the cool kids are doing it. It really takes a lot of willpower and a lot of courage to say no to gathering with people. In recent weeks, I had to, say no to my own grandmother that I couldn't visit her because I knew that I had been recently around other people. And so it's hard. This is really hard. That's the main thing I'll say is this is very hard. And I'm so sorry that you're all having to deal with this, that we are all having to deal with this. It is hard and it is scary. And I think everyone is, trying to do the best they can to keep themselves safe, physically, mentally, emotionally. But the key thing is to be aware. It's not helpful to be ignorant of these dangers. You do need to be aware of them and make the decision that's right for you, and really find out everything that you can find out about plans for being safe on a campus, and really stick to your common sense about not socializing, even though you really, really, really want to, because I know we all really, really, really want to.
Yeah, and just thinking smart about how you can socialize in ways.
So if you must see other people, be outside.
Yeah.
Wear a mask. Wear a mask that fits well.
Mm-hmm.
And think about your risk of infection increases with your proximity to another person, the ventilation of the space, and how long you are in place. I was, fairly horrified several months ago to hear of someone, a very grown adult, who was telling me about their dinner parties outside that they had been having, which, fine, this is great that they're outside, but they were sitting in one place for an extended period of time, eating a meal with other people and thinking that was perfectly safe. And I would say that's not. If you're at a park and you're passing somebody, try to, still keep 6 feet of distance and still wear a mask. But in that case, your risk is lower than if you are staying in one place for more than 15 minutes. And especially if you are in a place with poor ventilation.
Yeah, exactly. And I think as I've been telling the students in this class, the number of students in this class make up a significant proportion of the student body at WashU. And so they're building networks with other people who have the same information, who hopefully will be willing to communicate with them about how they could make plans, because we certainly don't want to see people isolated or mental health suffering, but we also don't want to see people being put in unsafe situations. And so it's good if they can use this space as a way to have a network of people that they can safely interact with on campus or off campus, remotely.
Right.
Yeah, that's great. So I'm going to just ask one last question. A lot of students are interested in the fact that you use non-human specimens as a way to study disease. Is there a big takeaway that you can think of something that is useful from your work that applies to what we're dealing with COVID?
Well, that's a great question. I mean, I think that, for example, plant pathologists have, a really solid grasp of how infectious particles move through the air. There's a lot of, for example, plant pathogens that are wind transmitted. Farmers know about spacing between rows and how that decreases the chance that, your different rows of your crop are going to spread disease to each other. I study this fungus on these common lawn weeds. This fungus is called powdery mildew. It's wind transmitted. And so in my lab, we think a lot about where, we both quantify in experiments, play around with different spacing of plants. But in the lab, we've already had protocols all along to try to avoid, airborne transmission, contamination of our different powdery mildew isolates between them. And so now in our lab, we of course have, overlapping protocols of the, keep our powdery mildews from infecting each other, keep each other from infecting each other, powdery mildew versus COVID-19. Really, a lot of the strategies are similar. Of course, different, targets of protection. But I really do think that, math is one of the, sounds super cheesy, but math is one of those, universal languages that really helps people communicate and really helps people figure out, what are the similarities that are maybe really useful, that we could really learn something in an applied sense that you could transfer between, plant pathogen or veterinary or wildlife animal disease situations to human health or in any of those other directions. But also to identify where we can't, and what is special about humans, and what is special about plants, and what is special about, non-human other primates or, rats or all of these other myriad animals in the world. So I think there's both really interesting just basic knowledge that we can get from thinking across different systems, and then the potential for innovations in how we model disease, how we predict disease, how we control disease, how we think about evolution. I didn't mention evolution here at all in this talk, but thinking about evolution of pathogens overcoming treatments like fungicides or evolution of microbes that are pathogenic to human overcoming our antibiotics. There's a lot of potential for thinking, cross-disciplinarily, and really not, wasting time reinventing the wheel in something that, this other field has known for decades now.
Yeah, absolutely. Yeah, I agree. And in terms of figuring out those calculations, it's much easier to do it when it's outside of the human system, I think.
Oh yeah, plants are the best for this. I mean, of course, you can't apply everything. There's a lot that you can't apply, but I do appreciate the fact that my plants, they stay in place. They don't lie to me.
That's right.
They don't sneak out and party, is what you get with them.
Yeah. Well, thank you. This has been great. And I really appreciate you taking the time. So thank you very much.
Thank you so much.
Yep. Have a good day.
Bye. Stay well, everyone.
Thank you. Okay, great. So it's now 2:00 and we are going to start with our second speaker for the day. Dr. Shanti Parikh is going to be talking about the stigma of testing, how community perspectives on COVID-19 are entangled with histories of distrust, inequalities, and ethics debates. Dr. Parikh is a professor in the Department of Anthropology at Washington University in St. Louis. Welcome, Dr. Parikh.
Thank you very much. I'm delighted to be here. Should I just go ahead and share my screen? Okay. So hello, everybody. Sorry that I cannot see you, but I'm excited that you all are taking this course. I think it shows great ambition, and I think it represents who our students are. So let me get started. Okay, Krista, can you see it? Thumbs up, okay. So as Professor Milich said, I'll be talking about COVID and stigma. And I'm particularly interested, so I changed it a little bit from just testing to looking at COVID stigma in general. And I want to think about what we know and what we know about stigma and what we can learn about stigma from past emerging diseases and from cases around the world. And I'll be talking a little bit about some of the work I'm doing in St. Louis around COVID. So first, and I'm in the Department of Anthropology. I'm teaching a global AIDS course this semester, so if anybody wants to take it, you are welcome. So first, what is stigma? As many of you know, it's a mark of shame, discredit, disgrace associated with a particular circumstance, quality of person, and discrimination. And it's particularly relevant for disease and health. And when looked at in disease, it's looked at the negative association between a person, group, or nation and a specific disease. And I'm sure you all are already starting to think about how this relates to COVID, but also other illnesses. Also, it occurs, people say, because of lack of knowledge, but also disinformation, fear, and prejudice. It spreads through gossip, rumor, myths. I should have also put the social media. I should have also put political talk. And it's based on the power of our ability to other people. So it's usually a particular group who has power or has some sort of status in the inequality matrix over another group. So what does this have to do? Health-related stigma is very old, and historians have been studying it for a long time. So just to give you an idea of how you can apply it to other illnesses that you all might be interested in historically. So back in 18th century, there were a lot of anxieties and fear about the syphilitic person wrapped up with morality. So this is called the scourge of mercury, when syphilis was treated with mercury, but lots of kind of grotesque representations that art historians show. During World War II, as many of you probably know, many soldiers died of STDs and not necessarily of the war itself. So the Public Works Administration put out a series of posters to warn soldiers about STDs. As a result, though, it doubly stigmatized women. So women became known as both loose prostitutes, sex workers, but also foreign women. So women who were in Europe at the time. So this was sort of a gendered way that stigma was wrapped through some of the public health messages. So for those of you who are interested, I just put up some of the key authors who write about this in medical humanities and historically. So Sandy Gilman, Susan Sontag, who also writes about HIV, and Paula Treichler. I think I'll share these slides if anybody is interested in sort of other ways that representations of diseased bodies and diseased people in air quotes, have perpetuated both fear of illnesses as well as distrust of healthcare system and re-stigmatized people. And during the Holocaust, certain representations of Jewish bodies became very powerful propaganda in spreading hatred. So this is the line of analysis that scholars who look at stigma and disease are coming from. I want to give a quick case study about HIV. So as many of you know, HIV was first reported in 1981. It was around before that, but this is when it was first identified. The virus was isolated in 1984. So that means there was a 3-year window between the actual reporting and when it was isolated. The test wasn't developed until 85. So what I'm getting at in here is we had a real extended period of time for lots of stigma, lots of discrimination wrapped around bodies who were seen to be spreaders of HIV. Antiretrovirals, which is the medicine that prolongs living with HIV, didn't come around until 95, 96. So case study, here we go. These are some of the earlier, during this gap period, oops, I forgot, I can't point to my screen. During this gap period, some of the panics, right? So the gay body became the idea of the vector of the disease. And again, you see heads of state becoming very important in promoting this message of homophobia, of diseased bodies. AIDS is not just God's punishment for homosexuals. It's God's punishment for a society that tolerates homosexuals. And so what this ended up doing was, of course, stigmatizing gay men, but also driving testing underground, and also people who didn't want to identify as gay, or maybe who weren't gay, didn't want to come out and say they're HIV because of the association. Second stage of HIV, I also want to look at how science can unintentionally perpetuate certain messages if we are not careful about the messages that we put out. This is called the cluster study, and I want you to pay particular attention to this. In a cluster, what people try to do is they try to say, here's a person, and it's almost like contact tracing. Here's a person, and where are the different people that they might have had contact with, so that we can, one, make sure that they get into testing, get treated, but also so that we can track the spread. This was not, when David Auerbach put this study out, he was not intending it to mean that this was the first AIDS patient. But in calling him patient O, in the cluster study it's O, and David Auerbach actually came to speak to my AIDS course once because his daughter was in the class. It got spun into the public media. This was probably a very innocent news story, but you see the translation from the O, the center of a cluster study, to patient zero, to people's living rooms who already have a fear of queer bodies, who already have a fear of foreign bodies, because Haitians were also known. And so this becomes spun into very harsh stigma and violence around the guy who actually was patient zero. Some of you might have also heard him called the French Canadian stewardess or steward and things like that. So I don't know if you can read this, but this is a patient zero thing, and it says pervert, get rid of, oh gosh, I'm not good at hangman, something, and we'll get rid of AIDS. I don't know, that's not bitches, something, bastards maybe, okay. And all of this earlier on in COVID, there was some talk about let's find the first patient of COVID, and that was quickly nixed by people who remember what happens when you search for this fictitious person called patient zero. Believe it or not, some people still want to trace it. The next phase of HIV stigma was and again, this is science and it is not intended to stigmatize, but when you put these messages out to a public who isn't necessarily conversant with it. So this here, some of this was to dispel the myth of patient zero, but as you can see here, this line comes from, and Krista, put your hand up if they can see my cursor. Can you also, okay, good. So this here shows that it's coming from Africa to Haiti to here. And so what this did was it sort of re-emphasized this idea of HIV being a disease of Black people, of Africa having sex with green monkeys, things like that. Again, I'm not saying that Michael Warby does great work. I'm not saying that. I'm more saying when messages go out, it's part of our responsibility to make sure that they land on the public in correct ways. And since then, he certainly has. All right, if people's hands are raised, am I supposed to stop, Krista? No, okay. Now on to COVID. All right, lesson number one that we have learned from calling it the Spanish flu, which of course it did not originate in Spain, but we still call it that. When we call HIV the gay plague, words matter, and words from leaders matter even more. I'll just leave this up. You all have already seen many of these. And I want us to think about what this means with stigma, and particularly as you come back to campus and we're in our WashU family. Don't let these subtle tweets that you already know are wrong subtly influence the way you treat your peers. Prevention messages. One of the things we also know is that regardless of our well-intentioned prevention message, they can sometimes get unfolded in ways that we don't intend. So this is, of course, showing the debate about the mask. And the reason why people want a consistent message about masks is because then you don't have to guess. Is the person wearing a mask because they're infected? Is the person wearing a mask because they think I'm infected? Is the person wearing a mask because they're a germaphobe? So that's why if somebody wears it, you don't want people to think, oh, they're wearing it because they are. The other thing, one of the things about these messages, and I hope we are all following them, but one thing I found in my research that I'll tell you about is that then if people go for testing or get COVID, I had one woman say in our research, well, I haven't done anything wrong. I shouldn't get COVID. As if people who get COVID have now all of a sudden done something wrong. So prevention messages just can't be about prevention. They also have to be how to treat people, how to destigmatize people once they have COVID. And that's a phase that the United States will be entering in hopefully soon. The rest of the world has. The World Health Organization has already promoted this destigmatize COVID campaign globally. Krista, do this if I'm going too fast. I'm trying to get through my slides. Okay. All right. Case study number one. One of my projects is looking at Black allied healthcare workers and COVID. And allied healthcare workers are a lot of times low-wage workers. They are the people who have most intimate care with patients because the docs and nurses kind of come and go, but these are the real caregivers. So these are the people who are involved in what some of us call affective care. So this is a case, this is an allied caseworker worker. She works three jobs, and because none of the jobs give insurance. So, but we just expanded healthcare. We just expanded Medicaid, so hopefully she'll have healthcare. She supports what's called a multi-generational household. So a grandparent lives there, she lives there, and then her children live there. The other adult in the household was furloughed during COVID. At work, she is on the lower end of what's considered risk because allied healthcare workers, the people who bring in your food, the people who change your bedpan or, take your blood or take your temperature, were not considered in the first sort of high risk. So she, at this particular place, she was afraid to ask for PPE, as you all know, protective prevention equipment. One morning, she felt ill. And she knew COVID symptoms well enough that she was very worried. But she knew if she went for a test, this is earlier on, she would ethically be required to stay home until she got the test results back. And she was on public transportation, and the closest testing center to her was one of them that took longer. She was also afraid if she told her work that she needed an expedited test, that she would also be sent home. She was afraid of loss of income, and she was afraid of fear of stigma, and she was afraid of losing her job. I know you want to know what happened, but I'm not going to tell you. Case study number two, the daughter of a COVID patient. Oh, I was trying to change the identities. So let's just say the offspring. So a 34-year-old daughter lost his mother to COVID. Not only could he not go and see his mom in the hospital, but he was required to quarantine. So again, with contact tracing, he had had contact with her before she was diagnosed. So he was quarantined. The one thing he was looking forward to so they couldn't have a funeral. The one thing he was looking forward to over the summertime was a family reunion that was being planned in a park, socially distant. They asked him not to come. Case study number three, the college student. Students return to campus. A student has COVID symptoms. The student goes for a test. While waiting, the student has to stay in the COVID designated area. That's a potential source of stigma. And you all have been reading the media about the universities that have already closed. And I have friends at those, and they are very concerned about how peers might treat each other during this time. Student from China gets a cold. This student does not have COVID. But because of subtle messages in our media, others are afraid of her. So my message to you is, as you come back to campus, treat each other gently, think about stigma, think about the messages that are out there, and we've got to support each other. All right, next, back to my lesson. I'm just going to show you some of these from around the world. I have not seen a lot of anti-stigma campaigns in regards to COVID. Sometimes, believe it or not, in terms of global health, the United States is a little bit behind the curve in what we're addressing and how we say things. This is another one. This is from India. Discrimination and harassment against COVID patients affects their mental health. It's time to fight the virus, not people. I mean, we certainly could use this in the United States. Do not stigmatize COVID survivors. The other thing we're seeing stigmatized are healthcare workers who are working in high COVID areas. And then I have tons of materials about what we should do to prevent stigma. I won't go into it now, but I can make it available, Krista, if people want to see it. But some of it has to do with words. So it's not called AIDS, it's not called COVID patient or COVID victim. So there's certain ways we can talk about it. I don't know if you all can see this, but stick to the facts. Respect and support healthcare workers who are testing those infected. Respect all frontline workers. Remind ourselves of practicing prevention. Okay, show compassion. People tend to hide their symptoms. We're seeing a lot of that. What we're seeing now, and I'm sure you all joke with your friends, somebody coughs and then somebody says, oh, you have COVID. We all really probably should stop doing it because the way COVID is spreading, you know, the likelihood of us knowing somebody who has COVID, had COVID, or is going to get COVID is high. So we probably should think about easing back on our cough/COVID jokes, diagnosing and containing. So lots of stuff, but I didn't want to go into too much about what we can do, but mainly just wanted to say my takeaway is, even though we think we're educated, there are sometimes unintended consequences of certain health messages and of certain news media. So I'm not even talking about the China flu, the Kung flu, those are more overt ones. Those subtly make their way into people's psyche. And of course, more directly, but even some of the more subtle ways that stigma might present itself in our everyday lives. And hopefully the 3 case studies will help to illustrate both how subtle it is, but also how we can be active and positive participants in this pandemic. So thank you very much. I'm going to stop sharing.
Great. Okay. Thank you very much. So I think that gave us a lot to think about. I mean, even some of those, little things, because I think a lot of people can recognize the more overt ways that we're adding stigma, but some of the little things I think aren't recognized as much. And so just to start off, for example, some of the students were wondering, okay, so if the naming of these things matters, some people are under the impression that it's okay to use Spanish flu, but not Chinese virus, right? And so in my mind, it automatically, I think of the 1918 flu, not the Spanish flu, right? So it's about using the proper terms rather than these sorts of terms. Did you want to add anything else to that?
No, Krista, I think you're right. I mean, I think I still hear it called the Spanish flu. I mean, you can look up Netflix, you can look up medical journals, and they call it the Spanish flu. I think the more precise we can be about the name of a pandemic, it did not originate in Spain, and would be better. I think the one reason why we're less preachy about not using it is because of the global hierarchies of race and where Spain falls. Mm-hmm. If it were a country that was stigmatized, it might be, but I would encourage students to not call it the Spanish flu. I think call it what it is. I think, the 1918 pandemic or flu would probably be more precise. Unfortunately, most people don't know it by that, but you could start that trend. Students, I'm pointing to you. Okay. Go ahead.
Absolutely. So we have quite a few students who have previously taken your HIV/AIDS class, and So we're really excited to hear you talk today. So we got some questions in advance also, as well as while you were talking. Wondering, so you gave us some good examples of the sort of stigma that was attached to HIV at the time. How does that compare to what's going on with COVID? What's the stigma that we're hearing a lot of with COVID?
I think for COVID, definitely Trump's calling out at China flu, Kung flu did not help. So I think we see that. I think we're going to increase it, older people. But I think there's going to start, because data is being released, and this is again one of the unintended consequences, because data is being released that low-wage African-American or essential workers are disproportionately impacted by COVID. I think you'll start to see that. We want those messages out. We want people to know that essential workers, low-wage workers, African-Americans, Latinx, queer, LGBT are more greatly impacted by this because of pre-existing structures of inequality, lack of access to healthcare. If not carefully messaged, it could be a disease of the poor. It could be packaged of, if you go into Schnucks and somebody coughs, so that's what I worry about. And I think that's why I put up the case study about the woman who works in the healthcare setting. She was actually very worried about that. It turns out she does not have COVID. I wanted to give you the results. So
good. That's great to hear. Yeah, I mean, I think maybe you could talk a little more about that, because that's something that the students were asking about. Given the disproportionate impact of this virus on marginalized groups, how do you then also mitigate the impact of stigma that that will add to their suffering, basically?
Yeah. I think stigma is connected to larger structures of access. So we really do have to make testing a more normalized thing. Instead of when somebody goes for testing, they think they're COVID. I mean, that kind of message is just not the way to handle a pandemic, particularly an illness that is so easily spread. I mean, this is the perfect spreader. At least HIV, you have to engage in an actual act. COVID, you call, it's just, there's nothing. So I think one of them is we really do have to routinize and make testing the norm. I think we do have to get healthcare out there. I think it's positive that states like Missouri have finally expanded healthcare access. So we have to make sure that is there. I think we have to make sure workers are protected in their workplace, because some of these essential workers could be easily replaced and easily fired. So that's where sort of workers' rights come into play, whether that's on this campus or somewhere else, but really protecting those who are most vulnerable. And really just education.
Mm-hmm. Yep, that's important. Students were asking about, how do you balance the need for testing with not wanting there to be stigma? And I think you just talked about that a little bit. We need to normalize testing so that there's not a stigma. But then they were also wondering, how do you balance encouraging people to follow safety measures or encouraging good personal behaviors that limit the spread of this disease with stigma, because that could be seen as related.
Yeah. And I think that's relevant as students come back to campus, right? I mean, that was the example of sort of the student who tested positive, as well as students from countries that are being stigmatized in the national, by the White House. So I think part of that is, one, as you come back, you really do have to choose your pot of friends and who you're going to interact with. And I think just take the same precautions with everybody. You are going to have some friends who are more intimate. That's just reality. You're probably going to have 5 or 6 friends. That's reality. And I think just make it a habit of, with everybody else, if you enter somebody else's dorm, if you enter somebody else's car, always just wear a mask. There's a poster that I did not put up, but it's sort of similar to the HIV, that COVID doesn't discriminate, it impacts everybody. Because, Krista, that was a phenomena that was going on in some places where they were seen as not as a risk group as with COVID, so they didn't see. So I think, really just being mindful of it is the first step.
Yeah. But I think also some students are wondering if they don't know what to recognize, how do you sensitize yourself to be able to recognize these things? Because I think some of the examples that you brought up are people hear them and they don't immediately realize that's associated with stigma, right? So for example, when you were saying, someone said, I haven't done anything wrong, I shouldn't be infected. Well, it's not that you did something wrong to get infected. So how, as you know, we have a lot of first year students in this class that will probably be moving away from home for the first time. How can they get used to reframing and re-seeing these common things that people say, like the Spanish flu, that are actually not really appropriate?
Yeah. No, I think that's an excellent question. When I send the PowerPoint, I'll send some slides that actually address that issue. And it's reframing it from a COVID victim, a COVID, somebody is guilty of it, to the idea that COVID is one of those things that can impact anybody. Again, in other countries, the World Health Organization, so that's called WHO, has a great campaign on the destigmatizing COVID. And it's all trying to reframe it, that it's not the person's fault. It's not, they're not the disease. That person isn't the disease. The COVID is, and that anybody is vulnerable. Anybody can get it. So I think it's really reframing it that way. It's not about what somebody did wrong. It's almost like what we had to do with HIV. And I'll send some of those. And again, I'm hoping that, gradually the United States will start to adopt some of the destigma COVID campaigns. I'd be interested, I don't know if you all can put your hands up, I'd be interested to see if anybody's seen any of those in your home areas. We are in the middle of the country, so sometimes things come here a little bit later.
I see people raising their hands, yeah.
Okay, so you've seen some destigma. Have you seen them here, Krista?
I haven't.
Yeah.
I would love to see them.
Yeah, I know in Atlanta they're there, probably, I'm sure New York, California, that's kind of where things usually start. But okay, some other students, yay. Good. Good. Well, if you do see those, if you do know, I would love to see what state you are in, because the rolling out of some of these messages is slow. And, this has really been a disaster in terms of managing the management of COVID and how we're dealing with it. I mean, that's an objective fact. That's not anything against the occupant.
If people want to go ahead and put where they're located, somebody says they have them in New York, you can put it into the question box. New York is what I'm
Gosh, these are great questions. Okay.
I know, there's hundreds of them. It's hard to keep track of them all. Louisiana, that's great. Houston, New Jersey, Maryland. Hey, Canada, Washington, D.C.
Oh, I love the one about breaking down graphs before gleaming information. Oh, definitely. Take my AIDS course. Yes. We have to be so careful about data. Yeah. And particularly and I'm sure, Christy, Professor Krista, your work is all about this as well. Definitely. I'm not saying don't look at the data, but the data only tells part of the story.
That's right. That's right. And I think that's a message that a lot of people in this class have been saying also, we need to don't just take what a scientist says at face value. You need to think about it critically, challenge it, slow down and analyze it. So that's great. Well, it looks like according to what people have put in the Q&A box, there are a lot of places around the country where they're getting these messages.
Good.
That's really good.
I haven't seen them here. They were supposed to start rolling them out.
Yeah, hopefully they do.
That is positive.
Yes. So another question that students had is the way that we do screening, testing, those sorts of things, does that affect the stigma? So for example, is self-reporting in order to track COVID cases or doing an online reporting system, do those things help with stigma, or do they just create more of a challenge for actually doing the necessary contact tracing?
Yeah, that's a complicated question because some of the stigma is self-stigma, right? So you have two types of stigma. You have stigma that is imposed on you, and then you have stigma that is a result of you being afraid that you are going to be stigmatized, or that you're going to be cast aside. I don't know if it's just about how we do testing. I think it's the whole package. And I think that's why we have to what's called routinized testing, where it just becomes a standard part of what's done until we can get a good treatment or get a vaccine. The at-home testing, I think in some ways could be very positive for people who really want to know, are afraid, and if they are at home, maybe they will take more precautions to stay at home or take more precautions to, because, it's the privacy of their own home. So I could see that being a benefit. I'm a big advocate of however we can get people tested in a positive way. I know some of the testing centers that I've been to actually are very, friendly and open. It's just long lines and they have to wait a very long time. And in the meantime, if they have symptoms, the contact tracers are out there and they're supposed to notify people. So there's a lot that kind of compounds the stigma.
Yep. And I think that's a really important message, right? It's not that testing is bad.
No.
It's that the way you frame it is so important. Adding stigma to it, and in any way making it a negative experience or making people feel like they've done something wrong by seeking a test, that's a great way to get off on the wrong foot with a good testing approach.
Yeah. It has to be compassionate. One of the things that we learned from HIV and testing is you want to give people hope. So all of these messages about COVID being the great destructor and, there's no cure and whatever, even though I just said it, people need hope, and people need to know that if you are, we're here for you. And I think from our research, sometimes people weren't hearing that. And then that's a big first step. And I think some of the people who are doing the testing are actually, really compassionate about it.
Yeah, that's important. And one of our other speakers also talked about the fact that you have to have social services in place for exactly the sort of scenarios that you were describing. If someone needs to stay home because they get a test and they're waiting for results or because they're positive, there needs to actually be infrastructure in place for them to get the things that they need during that time.
Yep. I love these questions. Yes, leprosy. Somebody asked, yes, leper colonies. I was worried that colleges would turn into that when they said I'm not saying WashU, but some said if students have symptoms or get COVID, they put them in I thought it was leper colonies. Definitely. That's a great one. Go ahead, Krista, you can.
No, I'm glad you're looking at the question. There's a lot of them, over 800 now.
Yes, so people are afraid to disclose. That's a huge issue.
This one I think is important for the students. So, you've spent your whole career working on these sorts of things, but for students who haven't had to engage people in these sorts of conversations, how do you start a conversation about destigmatizing COVID or any disease destigmatizing testing? How do you start a conversation with maybe your family members who aren't getting access to this sort of information like the students are? What should they say?
Gosh, that's a good question. I think we have to start at the end. And if our end goal, one thing I think, no matter where on the spectrum of politics people fall, the end result is to ameliorate the impact of this pandemic, as well as to slow the spread, to slow the suffering, to slow the deaths, and of course, eventually, come up with a vaccine that does something. So I think that's where we all stand in common ground, and maybe just starting there, and then starting by saying, look, if the end goal is to reduce the number of cases, reduce the number of deaths, reduce the number of families who are suffering, because as soon as one person dies of it, it's not just that person who's impacted, it's their family, it's their extended family, it's their friends, it's their workplace. So I think saying, if that's our end goal, by calling it the Chinese flu, say somebody called it, isn't really helping us get there. It's not helping to get us there by demonizing or stigmatizing a particular group. And we need to focus on the facts, and the facts show that Chinese Americans aren't any more impacted than anybody else. So I think if we just reframe it by starting with the end in mind, because I've heard a lot of things, but
yeah, that's good. And so then, if let's say students are asking, like, should WashU have a campaign for destigmatizing? I think you and I would both say yes, emphatically. Yeah.
It might. I don't know if it does. I haven't been to campus.
Yeah, I'm actually not sure either, which obviously as soon as I get off this call, I'll be figuring that out.
But I think certainly messaging among students is going to be important. Mm-hmm. We don't want students running from particular students. Mm-hmm. We don't want students running because they know a student is from New York or from California or is of Asian descent or of China or is from the place in China where it supposedly originated from, or they had a relative who had COVID, or they cough, or they get sick, or they already have a compromised immune system, so they have to take certain precautions that make them look like they're. So whatever you do for those, how many ever you are on there, be gentle with each other. And, we're gonna tackle this, but it's a serious thing.
Yeah, I think that's a great message, be gentle with each other. And a lot of students were putting in the question and answer box that, these in the places where they're living, the campaigns that they've seen, a lot of them actually haven't been from the government, they've been grassroots.
Yeah.
And so similarly, like you're saying, the students can be doing this work on their own as they return to campus.
Yeah. And can I ask them one thing? The government, because I think the mask thing might not be on some of the CDC things. When I tried to find it, so because our government is having a bit of confusion around how to deal with this. Yes, I think you're absolutely right. Whoever put that in there, it's local public health departments, and it's grassroots, meaning like, non-for-profits or so do that. And I think if I ask you for students, if you do it, put something on there about stigma. We love infographics. I showed you the ones that I showed are always graphics. Have one that does pull from the messages about how to treat people who've had COVID or whose relatives have had COVID. I'll give you some words that you can use to put on it. Don't call them AIDS victims. Don't call them COVID victims or COVID sufferers. There's certain language. So as you make your infographics, promise me that 1/3 of your infographic will have something about destigmatizing.
Yeah, well, that actually leads perfectly into the next question, because students were asking, what should a campaign like that look like? So what are the phrases that they should be using, and should they be focusing on infographics, or what's the best way to get those messages out?
I say health communication, which that's not my specialty, even though I teach on it, but there's a whole field called health literacy, health communication. And there's some people in the Sam Fox School of Design. There's some people in the School of Social Work. Krista and I do some of it, but infographics are always useful because it draws people's attention. But you of course have to be careful about the infographics you use. So it's always trying to find that balance. I like infographics because they're easily recognizable. And then you always have to have words. And we always say that your health messaging has to be pitched for somebody at an 8th grade level. One, even if somebody's college educated or has a PhD, they're not going to sit there and read a bunch of words. The thing about stigma, I'll pull up the slide, but I think, there's some good ones. I took some of the things off, but there's some good ones that I saw out there that I can share with you. But I'm going to look for, like this one says, this is a good one. The one that says, it's time to fight the virus, not people. And then there's a bunch of them that say about that give nice messages and slogans about how to treat people who've lost somebody to COVID or who have COVID.
Yep, that's good. And I mean, just remembering to show kindness and think about the people behind this, So a student was mentioning that they had heard that people were recommending calling it the China virus or the Chinese virus because it's trying to hold the Chinese government accountable for things like the markets where this disease probably originated, any sort of practices like that, any sort of lack of communication that they provided at the beginning. What are your thoughts on that?
You know, I think that's not the best way to keep a government accountable. You know, I think we should keep governments accountable for things, but keep the government accountable. You don't need, you know, by calling it the China, you're stigmatizing the entire population. You're stigmatizing the entire, and I, you know, I'm not saying China was wrong or right, but let's say there was a country that did handle it poorly. Let's just assume that. You don't want to stigmatize everybody from that country just because they're I mean, that's like somebody stigmatizing us because of the people we elect. So I think calling it the Chinese flu is not the way to keep China accountable for markets or for hiding data or for being slow to respond. If indeed they were, I'm not saying they were. That's certainly, you can hold the Chinese government accountable without stigmatizing the entire population, both in China and China diasporic residents or people.
Yep. Yeah, that's great. And I mean, there are also some students on the Q&A from China who are saying that they're really appreciating the messages that you're providing.
Yeah. It's almost like, you know, HIV, when people called it the gay plague or the gay virus. One, it stigmatizes gay men. We know that. You know, I think that's nicely documented. Two, it also meant other people weren't susceptible to it. So calling it the Chinese flu makes it what? You know, I think, so we also have to think about that. Okay, go on. Sorry.
No. I think this is great. Students are asking also if you think that what stigma about COVID has to do with voting, other things going on socially within our communities, those sorts of things.
Oh gosh, that's such a good question. Yes. You know, we're in an election year. The most important thing you can do this semester is to vote, get registered, make sure you make it your obligation to get 2 or 3 or 4 people registered, vote early, help people get to the polls. Everything that's going to happen for the next few months at the policy level is tied with politics. And you saw the Democratic convention, COVID came up a lot. I'm sure the Republican convention this week, COVID will come up a lot. That's unfortunate. You know, pictures of mailboxes being taken down and then people saying that was already going on under. So, you know, unfortunately, you know, in my AIDS course, what I always say is that if you go into health, whether it's a doc, a nurse, a public health person, research, health, medicine, disease, treatment is so embroiled with politics and with other things and with the economic system that, you know, be mindful of that. So in terms of what you can do, I think go out and vote, keep yourself informed.
Yep, that's great. We're actually down to our last couple minutes. So I think that's everything you've said is really great advice. And I feel like we've covered a huge range of topics. But I guess I just want to give these last couple of minutes for if there's anything that you haven't gotten to mention that you think it's really important for students to know as they plan to come back to campus or to engage remotely this coming semester and as we just continue on in this pandemic.
Yeah. I'm just gonna quickly flip through to make sure I'm addressing, you know, somebody wrote, and I won't read the person's name, but the person saying, any advice for someone who's facing stigma from friends, family? I am positive for COVID and I'm in proper quarantine. I was very careful, but I got it anyway. Physically fine, but I'm very embarrassed. That's stigma.
Yep. Sorry, I didn't even see that sentence.
Stigma. Mm-hmm. So that is exactly how stigma works, because that's called self-stigma. So any of that embarrassment that this person is feeling, stop it. We have to support each other. I don't know what to say other than it's a social shift that has to be made. You did not, I mean, this is it. I mean, this is exactly what I kept finding is that people who tested positive felt guilty. They felt ashamed. And this is where I think contact tracing, we really have to do it carefully. It's not your fault. If you get COVID, it's not your fault. This thing is so easy to spread. That's why people should wear masks. That's why people should wash your hands. Some people are more susceptible just because of, vulnerabilities or whatever. I'm sure we're going to find out, something that we didn't even expect, but your nose canal makes it, but something that's not even related to it, we're going to find out. These things are very bizarre. So if I be kind to each other. I think we should assume, my husband always says in a positive way, I think we should assume everybody has COVID and be very careful about what you say that means. Don't joke about it. Treat people carefully, but also protect yourself. So saying that everybody has COVID doesn't mean you're going to stigmatize or other everybody, but it means you're going to be aware of the COVID jokes you say. You're going to be aware of, quarantine this, because chances are, probably in every 4 people you see here, one of those people is going to know somebody whose lives was affected by COVID. I keep saying HIV, by COVID. So yeah, be gentle with each other. Take care of yourselves. Don't go, definitely wear your mask. Find one that's comfortable. Wash your hands. Keep your hands clean. And we will get through this. I think I know in classes, we're really trying hard to give an in-person safe experience. And we just have to pull through this as a community. And I think we will.
That's great. I love that. I'm glad that we're ending on that message, because it's good to remember to be gentle with each other and also with ourselves, and that we will get through this together. So thank you very much, Dr. Parikh. It was wonderful to have you.
Bye, everybody. Although I can't see you, good luck. Have fun at school. Take my AIDS course. Yay. All right. Bye.
Great. Thank you very
Krista.
much. Bye. And everyone else, I will see you tomorrow. Until then, stay safe.
Do I get on or
They'll kick us off in 1 minute.
All right. Well, good seeing you, Krista.
Bye.